Today we'll be discussing about acute laryngotracheobronchitis. As the name goes, acute laryngotracheobronchitis is the inflammation of the larynx, trachea, and bronchi. It is also known as Croup. The most common terminology, that is acute laryngotracheobronchitis or Croup, is used for a viral infection. So it is most commonly caused by parainfluenza virus type 1. It can also be caused by parainfluenza virus type 2, respiratory syncytial virus type A and B, rhinovirus, pneumovirus, coronavirus, Boca virus, etc. What is the pathophysiology? The pathophysiology is there is mucosal edema due to infection of the larynx, trachea, and bronchus. But although there is mucosal edema everywhere, the most common symptom is hoarseness of voice, barking, cough, and stridor. Stridor is inspiratory stridor. I will come to the symptoms. So before that, I will tell you the pathophysiology. The pathophysiology is mainly due to edema of the subglottis. In children, in pediatric upper airway, the most narrowest portion is subglottis. Also, the cricoid cartilage forms a complete ring. There is no space for expansion when the mucosal edema occurs. Subglottic edema is the most common cause for the symptoms in Croup. Subglottic diameter of neonate is around 4.5 to 5.5 mm. So imagine like a 18-month-old child having a 6.5 mm subglottic diameter. Even 1 mm reduction in that diameter due to mucosal edema can cause a significant reduction in the cross-sectional area, almost by 50%. According to physics, according to Poiseuille's law, the laminar flow is proportional to the fourth power of radius. So because the cross-sectional area is reducing too much, the laminar flow is reduced and the child will develop stridor. What are the predisposing factors for this subglottic edema? If the child is having a chronic lung disease, or child is having chronic allergy, like allergy to inhalant agents or any dust or any food allergies. If the child has a pre-existing subglottic or tracheal narrowing, a small viral infection with a minor subglottic edema can precipitate the stridor. So all this have to be kept in mind. And also, if a child is getting recurrent viral infection, recurrent Croup, you have to investigate for mild acquired or congenital subglottic stenosis. What is the clinical presentation? The Croup is most commonly seen in young children from 6 months to 3 years of age. Some books say 6 months to 6 years of age. But Scott Brown says 6 months to 3 years of age. The peak incidence is from 12 months to 2 years. It is most commonly seen in boys than in girls. The parent will give a history of the child having an upper respiratory infection like rhinorrhea, nasal discharge, nasal congestion, fever, malaise, etc. Followed by the child developing hoarseness of voice, a barking, cough, and stridor. The stridor will be inspiratory stridor, high-pitched inspiratory stridor. The child can also develop biphasic stridor. And on examination, you can auscultate the stridor. If the child has developed a lower respiratory bronchitis also, the child will have wheeze, crackles, and tachypnea. The child will not appear too much toxic, or there won't be any drooling of saliva. The drooling of saliva and toxic look is there, means you have to think about acute epiglottitis. So the child will have mild fever, the child will be okay. The diagnosis is mainly clinical. Child in the age group like 6 months to 3 years. History of upper respiratory infection followed by hoarseness of voice, barking, cough, and stridor is coming to you. First of all, the diagnosis should go for acute laryngotracheobronchitis or Croup. Laboratory studies and radiograph investigations are not required. But if you have a doubt, you can take a radiograph. The X-ray neck AP view will show a narrowing of the subglottis, that is known as steeple sign or the inverted V sign or pencil tip sign. This can be an MCQ question that can be asked for your exam. So steeple sign is seen in Croup or acute laryngotracheobronchitis. In a patient with recurrent Croup, where you are suspecting subglottic stenosis, mild subglottic acquired or congenital subglottic stenosis, here we can go for an endoscopy. So what is the treatment? There is a score, Westley Croup score, which can be used to categorize the Croup into mild, moderate, and severe. It includes the inspiratory stridor, retractions, air entry, cyanosis, conscious levels. So 5 points are included in the Westley Croup score. I have made it into, you can imagine CROUP, P for cyanosis and conscious level, R for retraction, O for obstruction sound, that is stridor. You can use U for the unconscious level, but I have added it C itself, consciousness and cyanosis. P you can use for pulmonary air entry. So cyanosis, conscious level, retraction, obstruction sound, stridor. P for pulmonary air entry. You have to keep in mind that cyanosis and conscious level, cyanosis and altered conscious level come into a higher point. You can see the table. The maximum score is 17. Any score between 2 to 3 is mild. 4 to 7 is moderate. More than 8 is severe. Like this, you can classify the Croup diagnosis. Most of the patients, it is self-limiting. The disease is self-limiting. 50% of the patients improve within 24 hours after onset of symptoms. A majority of cases recover within 4 days without treatment. This is what Scott Brown says. 50% recover within 24 hours after onset of symptoms, and majority recover without any treatment in 4 days. But when a mother or a parent comes to you with a child, cough, barking cough, hoarseness voice, stridor coming, sound coming, if you say nothing is there, you go home. That is what you have to do? No. We know that they recover within 24 hours or 4 days, but we have to observe the child because the child can progress and get worsen. There's a chance for that. So you always have to observe the child. Another thing is, whenever you are examining the child, you should not agitate the child or irritate the child and make the child cry, insert tongue depressor and irritate the child, because any agitation can cause dynamic obstruction and the stridor will increase. The child has to be comfortably seated on the parents or caretaker's lap, and you can examine. Mostly it is a visual examine, observation of the retraction, the stridor, how the child is behaving, how toxic the child is. With that observation itself, you can get half of your diagnosis and your findings. So if it is a mild, that patient is having 2 to 3 score, it is a mild group, you can tell the caretaker that this is what is happening. There is edema of the mucosa. That is why the sound is coming. You can admit the child and give any supportive treatment. If there is any fever, you can give paracetamol. If the child is dehydrated, you can give IV fluids. All this can be given. But we should make sure that you should not give any sedatives to the child. Sedation can increase the stridor and it will be difficult for us to assess the worsening of the disease. And it will be better if you can keep the child in a well-humidified environment. What are the medical treatment? That is, what are the treatment available? The goal of our treatment is to reduce the airway obstruction. So we have to create more space. So the most common drug that is used are corticosteroids. Corticosteroids have systemic anti-inflammatory effects. Topical steroids also cause some alpha-mediated vasoconstriction. So we can give corticosteroid dexamethasone 0.6 milligram per kilogram. Maximum dose of 10 milligram at one sitting. Studies have shown that children who receive corticosteroids recover faster and they have lesser hospital time. So even in mild group, you can give a single dose of oral corticosteroid. The steroid is usually given orally only, oral corticosteroid, not IV or IM. IM corticosteroids are not advised because it can cause muscle necrosis. So you either give orally, or if the patient is vomiting and not cooperative and the child is not eating anything, you can give nebulized budesonide. You can nebulized steroid, 2 milligram budesonide you can nebulize. So in mild group also you can give steroids, single dose steroid can be given, and then observe the child for any worsening of symptoms, any increased breathing difficulty, any worsening of the cough or worsening of stridor, etc. You can observe. Another drug that can be used is nebulized epinephrine. 1 ml of 1 in 1000 epinephrine diluted with 3 ml of 0.9% saline can be used for nebulization. It reduces the mucosal edema. Epinephrine has alpha agonistic activity, so it causes vasoconstriction and bronchodilation. Another thing about epinephrine is it is symptomatic treatment. It does not affect the course of the disease or it does not treat the disease. It reduces the mucosal edema so the child gets a symptomatic relief. And the effectiveness of the epinephrine starts within 30 to 60 minutes and it lasts for around 2 hours. After 2 hours, the result goes down. For steroids, the results last around 12 hours. The result for 1 dose of steroid doesn't last for more than 24 hours. So if you're keeping the child in an observation in a daycare or in an emergency, you are giving steroids and epinephrine. And within 2 hours, again, the child is requiring another dose of an epinephrine for nebulization to maintain the reduced stridor state. It is better to admit the child and go for further closer examination. Another treatment that you can give is you can give oxygen via nasal cannula, supplementary oxygen via nasal cannula in children who are hypoxic. And in severe cases, hypoxia not responding, you will have to go for an intubation and mechanical ventilation if required. Another treatment that is available now is Heliox. It is a mixture of helium and oxygen. 70 to 30% or 79 to 21%, both mixtures are available. The helium is less dense than air and is more viscous, so it produces more efficient flow. If the helium is delivered through a high flow system, It maintains good tidal volume and reduces the respiratory effort. So some centers use Heliox also. The main thing is close observation. If it is a mild side or if you're discharging the patient, the caretaker or the mother or the parents has to be convinced that it is better and it can get worse and they should be living nearby or transportation should be available so that they can come anytime. Otherwise, if it is moderate or severe cases, admit the patient, observe for 3 days and discharge once the symptoms are better. What are the differential diagnoses? One differential diagnosis I told earlier itself, drooling, toxic child, acute epiglottitis, any foreign body aspiration, any subglottic stenosis can present like this. Any anaphylaxis, any peritonsillar abscess, all this have to be ruled out. Another differential diagnosis, bacterial tracheobronchitis, that is also known as pseudomembranous Croup. It is caused by bacteria. Bacterial tracheobronchitis is usually seen in elder children, 4 to 8 years. This is also more common in boys than in girls. The child will be toxic, high fever, and the child will not be responding to your nebulized epinephrine or steroids. It is usually caused by bacteria, Staph aureus. Also, Haemophilus influenza, Moraxella catarrhalis, Streptococcus pneumonia, Pseudomonas aeruginosa can also be isolated from the swab if we take. It can also occur as a post-viral secondary bacterial infection. So initially, the child will get a viral infection, then develop into a bacterial tracheitis. Sometimes in the swab or if you do a PCR, you can isolate H1N1 influenza virus RNA also. This is a life-threatening condition. There is profuse discharge and fluffing of the epithelium and profuse mucus production. And this discharge and slough and phlegm is adherent to the trachea and bronchus and larynx, which cannot be coughed out by the child. So in these children, when suspected, we have to start broad spectrum IV antibiotics. And also you have to do an endoscopy, tracheobronchoscopy under general anesthesia. You will be observing a pseudomembrane over the subglottis, trachea, bronchus, etc. This has to be removed, suctioned out, and pulmonary toileting has to be done. Also, these children may require endotracheal intubation for a period of time until they recover. And also, when they are intubated, because of this profuse secretions, there can be chance of this endotracheal tube getting blocked. So, frequent tracheobronchoscopy and removal of the secretions may be required in bacterial tracheobronchitis. The complications are there can be airway stenosis, ARDS, child can go into toxic shock syndrome, encephalopathy, etc. To summarize, acute laryngotracheobronchitis or Croup, viral infection, para-influenza virus, Westley scoring system, steeple sign. It is mostly self-limiting. Treatment can be steroids, nebulized epinephrine, oxygen can be supplemented. Some severe cases require intubation and Heliox can be used. Differential diagnosis include bacterial tracheobronchitis, if it is not responding to treatment, may require systemic IV antibiotics and intubation.